We are pleased to provide the video recordings of Florida Digestive Diseases update held on December 4th and 5th, 2021 in Orlando, Florida. This is the video recording from Session 3 on functional bowel disorders. This session featured lecture on chronic constipation, pelvic floor dysfunction or dysmotility by Dr. Satish Rao, followed by approach to gastroparesis and small bowel dysmotility by Dr. Michael Camilleri, then an update on gut microbiome, explanation for all that ails us by Dr. David Johnson. The last lecture of the session was on abdominal pain, nothing seems to work, by Dr. Michael Camilleri. The session was concluded with case presentations and discussion with Dr. Christina Covelli. Please enjoy the session.
It's a pleasure to start off this next session, which will be on functional bowel disease. I want to introduce my co-moderator, Christina Covelli. Christina trained at UAB in GI, and as V sort of likes to say, I think for all of us, me included, if we have a family member, a friend, somebody that needs a great gastroenterologist, Covelli is the one that we send them all to. She's a unbelievably superb clinician, a great communicator, and just a solid individual. So she'll be doing the case presentations at the end, which will stump Dr. Camilleri and Dr. Johnson, and they'll be fumbling and not knowing what to do. And Covelli will rescue them, I'm sure, from the case presentations. We're going to first introduce Satish Rao, and I'm so sorry that he can't be here in person. He is one of the most wonderful people that certainly I have ever met, but he had some issues that made it not possible for him to be here. He's recorded his talk, and so it will be recorded. For those of you who don't know, he's a professor of medicine and director of neurogastroenterology motility at the Medical College of Georgia. I think just a fantastic, one of the best motility people in the world. So I think we're queued up for his talk, and we've asked him to talk about chronic constipation, pelvic floor dysfunction, or dysmotility. So hopefully, without further ado, we'll get Satish up on the screen.
Good afternoon. I'm Dr. Satish Rao from Augusta University. I'd like to thank Dr. Shyam Varadarajulu and the entire organizing team for inviting me to this important conference, and I'm sincerely sorry that I'm not there in physical form to present this talk. I appreciate the opportunity to provide this video talk. The title for me was Chronic Constipation, Pelvic Floor Dysfunction or Dysmotility. Here are my disclosures for my talk. And the objectives for my presentation are to define the various constipation subtypes. Most people lump all constipation into one group, but let us explore two key common pathophysiological subtypes. And I will use these cases to illustrate clinical evaluation, how to use apps and diaries, digital rectal examination, and diagnostic testing. And then let's review the latest treatment options for these patients using a pathophysiological based approach. Chronic constipation is a common problem in the general population. Women outnumber men 2 to 1 in the Western Hemisphere, and there is a significant age prevalence with older individuals suffering more with constipation than younger individuals with a higher prevalence. Now, clinically and pathophysiologically, we can subtype constipation into multiple categories. Occasional constipation really describes symptoms of fleeting transient constipation lasting for a few days to a few weeks. Most of us would have suffered with this, particularly when we travel or there's some change in our diet or stress and so on. Dietary causes and fiber deficiency is all too familiar and well known. But when we discuss constipation, we mostly refer this as chronic constipation. That is when many patients come to see us, at least in the GI clinics. Here, I wish to categorize them into three main subgroups: primary constipation, secondary constipation. And although opioid-induced constipation is part of secondary constipation, I think given its high prevalence in the United States, and now that we have selective drugs for this, we can regard this as a separate category in its own right. And we will explore this. But within the primary category, we have slow transit constipation, dysenergic defecation, and irritable bowel syndrome with constipation, and some specialized pelvic floor disorders such as rectal hyposensitivity and rectal hypersensitivity. Now, in the primary group, as I mentioned, we have three broad overlapping subtypes of constipation. There is irritable bowel syndrome with constipation, which many of you are familiar with. These patients often report pain, bloating, and discomfort with an altered bowel habit. Many times they may have a normal transit and normal pelvic floor function. Then you have slow transit constipation, where the rate of propulsion of stool is significantly slower than normal individuals. And then you have the evacuation disorders. And in this, the main subtype is dysenergic defecation or incoordinated active defecation. Now, there are other causes that also contribute to evacuation disorders such as rectoceles, descending perineum syndrome, rectal prolapse, etc. And these also contribute to evacuation disorders. Let me illustrate this with this case. A 31-year-old school teacher came to see me with a 9-year history of progressively worsening chronic constipation. Her bowels typically move once every 2 weeks. She reports hard pellet-like stools only after using fleets enema, suppository, and laxatives. She has frequent digital maneuver use, excessive straining, and incomplete evacuation. She tried over-the-counter laxatives, milk of magnesia, and PEG. There was no relief. So typically, what would you do next? One of the important things, clinical tools we use is a detailed history, but we know, and we've learned from recent studies, that there is significant recall bias. And when the bowel habit is irregular, patients always struggle to provide the truth and the real information. So one way to assess this better is to use a prospective stool diary. And we can use now digital apps, and I'll talk about that in my next slide. The next important tool is a good general and particularly digital rectal examination. We'll talk about that briefly. Many people use colonoscopy, but this is mostly useful in those with alarming features and in those over the age of 50 years. Physiological tests are key for managing constipation. One is colon transit study, either using radiopaque markers or scintigraphy in specialized centers like Dr. Camilleri Center, and wireless motility capsule. And then we have a simple balloon expulsion test where we place a 50 ml water-filled balloon in the rectum, have the subject expel this in a minute, or a specialized device such as the FECOM, which is not available commercially. And then you've got the radiological test, which is defecography. Some barium paste is inserted in the rectum, have the subject expel this, and continuous fluoroscopy is performed, now increasingly using MRI, because the barium defecography has almost become obsolete. And then finally, and importantly, anorectal manometry, which is very critical for diagnosing pelvic floor dysfunction, particularly dysenergic defecation. And then importantly, colonic manometry. Now, there are several diaries available. This is a common diary that we've used, evaluated, and validated. But recently, we have worked with a company to develop a diary app for constipation symptoms. This is now available, I believe, in App Store and Google Play. There are several screenshots, about a dozen of these. Here are some examples of stool consistency, stool frequency, straining effort, use of fingers, etc. And patients can record this very easily. It takes a minute or two. And in this preliminary abstract we presented 2 years ago, we evaluated the retest reliability and validity using a number of measures. And suffice to say that if you look at a number of complete spontaneous bowel movements, for example, there is very good ICC correlation between week 1 and week 2 and overall validity when comparing to the validated paper diary. Thus, this seems like a very good tool for assessment of constipation symptoms. Now, when it comes to digital rectal examination, there are 3 key steps. 1, inspection of the perineum. 2, the inocutaneous reflex, grading that into normal, impaired, or absent. And then finally, placing your gloved index right finger with a chaperone around and good light, and having the subject squeeze, and then push and bear down. And during the push maneuver, you're assessing for how much they're able to push with your left hand. Also assess the anal sphincter relaxation and perineal descent. And clinically at the bedside, you can confidently identify dyssynergia if any two of these mechanisms are not present. That is, they're not able to generate a push force that is not contract abdominal muscles or relax anal sphincter. Instead, they're showing paradoxical contraction in anal sphincter, or there is impaired or absent perineal descent. If any two of these are present, then you can raise the suspicion for dyssynergia. Now, the most important tool, of course, is anal rectal manometry. And there are multiple subtypes of this dyssynergic defecation, and allow me to walk you through this. Let's assume we place a simple manometry catheter in the rectum, one sensor in the rectum, one sensor in the anal canal, and you have a normal subject push and bear down, and this is the pattern you will see. Nice rise in rectal pressure, coordinate with anal relaxation. And if you look in a topographic mode, which is all the color mode, the blue color is a soft, nice color, which is atmospheric pressure. The yellow, orange, red means higher pressure. And you can see when the subject pushes, they generate a good push force, coordinated with a nice anal relaxation. Here are the various subtypes of dyssynergic defecation, and you can see in type 1, there is significant increase in rectal pressure, and instead of relaxation, there is paradoxical increase. See this topographically, increase and increase. Here in type 2, there is poor push, but paradoxical increase. Type 3, there is adequate push, but incomplete relaxation, poor push, and poor anal relaxation. All of these subtypes constitute the various types of synergic defecation. How do you treat dyssynergia? General measures, diet, exercise, fluids, habit training, laxatives, the famous squatty potty are all very important. Specific treatments that have been tried are Botox, has never really worked. Cognitive behavioral therapy was not very effective. In the beginning, people thought that dyssynergia was a spastic dysfunction of the anal canal, and therefore myectomy was performed, only 30% improved, and in some difficult cases, colostomy is performed. But the main stay of treatment and has been well researched and proven is biofeedback therapy. We'll come back to that in a minute. But let me talk about over-the-counter therapies for constipation. In a recent paper published in the American Journal of Gastroenterology, you can see that we reviewed previous data in the systematic review of evidence for various over-the-counter laxatives. And now PEG is the one that has a grade A recommendation, followed by Senna has also got good evidence for that, and bisacodyl and sodium picosulfate. Magnesium has grade B, and likewise kiwi, mango, ficus, prunes have various levels of grade B evidence recommendation for this condition. Now, biofeedback therapy, the goals of biofeedback therapy are to teach diaphragmatic breathing exercises, teach anal sphincter pelvic floor relaxation, improve rectal sensation, eliminate sensory delay, and improve rectoanal coordination. Now, there are multiple large randomized control studies done across the world. All of them show that biofeedback is superior to laxatives, sham therapy, and standard therapy. And in a recent study, we compared home biofeedback versus office biofeedback and showed using more rigorous endpoint where a responder was defined as more than one complete spontaneous bowel movement plus normalization of dyssynergia pattern, approximately 70% of those who received biofeedback at home or in office improved. Here is our patient before biofeedback showing the paradoxical increase, and after biofeedback now showing beautiful relaxation of the anal canal. Let me talk about another case. A 40-year-old nurse, severe constipation, pain, gas, and bloating, was over 2 years on Depo-Provera, now became completely refractory to all laxatives and secretagogues, was being referred because they wanted colectomy. Now we performed standard batch of investigations. One of the first tests we did was a wireless motility capsule test here. And here you can see that this is the wireless motility capsule, and 5 days later the capsule is still hanging on in the splenic flexure region. And we also combined this with markers, and several SITS markers are also seen here. Overall, we found that our gastric emptying was delayed, small bowel transit was normal, but colonic transit was significantly delayed compared to healthy normal subjects. Because she was being considered for colectomy, we wanted to definitely evaluate whether her colon is normal or there is evidence for underlying muscle dysfunction or nerve dysfunction. To do this, we place an ambulatory colonic manometry probe with 8 pressure sensors and record 24-hour ambulatory colonic manometry. The blue profile is the normal values in 25 healthy subjects, and you can see that after a meal, there is significant increase in colonic motility. When they sleep, there is decrease in motility. When a subject wakes up, there is significant rise again. You contrast this with our patient here, who overall has diminished motility, but does show a waking response and does show a meal response, showing that underlying neurologically there is a neuromediated response is intact, but the muscle is very weak. In other words, she has myopathy. We've investigated 84 such patients over the years, and we found similar kind of patients, and we found that about 41% had normal colonic manometry. In other words, the muscles and nerves were intact. But about 26% were like this lady with colonic myopathy, where the muscle is weak, and 33% had colonic neuropathy. And the significance is that this is the neuropathic group that is clearly refractory to medications, biofeedback therapy, and so on. And that is the group that is more likely to benefit with. But in this patient here, of course, she clearly had a myopathy and no neuropathy. And therefore, we explained all of this. We placed her on lifestyle and behavioral diet changes. We asked her to discontinue Depo-Provera, which has a strong progestogen effect and slows gut motility and may have been the cause of her myopathy. We placed her on Prucalopride 2 milligrams with food, and 6 weeks later she followed up, reporting bowel movements every 2 to 3 days and type 4 and feeling much better. So my last 2 summary slides are really focused on constipation in a hospitalized patient. Acute constipated hospitalized patient, think about 3 real possibilities. Number 1, fecal impaction. If so, consider under sedation, careful disimpaction with enemas, eventually bisacodyl, PEG, and laxatives. Once you have successfully achieved this, please find out why they became infected and try and correct the underlying problem. That is very important, not just taking care of impaction. Second, if you have opioid-induced constipation, this can present acutely in the hospital, sometimes even with Ogilvy. So we have methyl-naltrexone, certainly discontinue opioids, and lubiprostone, naloxegol, naldemeline, and there are several drugs now that are approved for treatment of opioid-induced constipation. Post-op ileus, alvimapam is the main drug used. Now, with regards to chronic constipation in the outpatient clinic facility, if you can subcategorize them into the 3 main subgroups: slow transit constipation, IBS with constipation or dyssynergic defecation, and then you can follow this. For slow transit constipation, we have several good drugs now. Secretagogues include linaclotide, lubiprostone, and plecanatide, guanylate cyclase agonists, as well as chloride channel 2, and prucalopride is a serotonin agonist. We also, in the future, will have elobixibat, which is a bile acid blocker, SNS, and perhaps the Vibrant capsule technology. And then for IBS constipation, linaclotide, lubiprostone are approved along with plecanatide. Some people use PEG, and SSRIs really are important, or some low form of antidepressants for treatment of underlying pain, which is an important problem in these people. Perhaps in the future, maybe prucalopride, and certainly hypnotherapy and cognitive behavioral therapy is very effective in the management of IBS symptoms. For dyssynergic defecation, of course, biofeedback therapy remains this mainstay and is the best modality of helping them, and perhaps in the future, home biofeedback therapy. Thank you very much for your attention, and I wish all the best for this conference. Goodbye.
I really wish he could have come, but he's a wonderful guy. But that, as usual, he delivers an excellent talk. Our next speaker for this session is Michael Camilleri. Michael is, I think, probably known to all of you very, very well. He's a named professorship at Mayo Clinic in Rochester. He's a professor of medicine, pharmacology, and physiology in the division of gastroenterology. I think that anything functional, anything motility-wise, Michael is at the top of the heap in understanding those. He's a incredibly well-published, well-studied individual. And so he's actually going to be giving 2 talks during this session. The first one is the approach to gastroparesis and small bowel dysmotility. So Michael, welcome.
Thank you very much. Thank you, Rob. Thank you, Orlando Health, for the invitation. It's great to be leaving Minnesota at this time of the year, even though the snow is not quite permanent on the ground yet. Okay, so my learning objectives are to review the definition, epidemiology, pathophysiology very briefly, and diagnosis of gastroparesis, dietary and pharmacological interventions. I'm going to spend a fair amount of time talking about the new kid on the block. And the new kid on the block is obviously G-POEM procedure, pyloromyotomy, and then we'll have some additional considerations briefly regarding small bowel dysmotility. So the major focus is going to be on gastroparesis. These are my disclosures over the last 24 months, including research grants, consulting, and some stock options. So let's start off with the guideline definition from the American College of Gastroenterology document, of which I was very fortunate to be one of the authors. Gastroparesis is identified in clinical practice through the recognition of clinical symptoms, documentation of delayed gastric emptying, and the absence of gastric outlet obstruction. And the symptoms are well known to you all: nausea, vomiting, early satiety, postprandial fullness, bloating, and upper abdominal pain. Management, obviously, we're going to talk about this, but remember the diet, the blenderizing of the diet, and I'll give you evidence for the importance of the small particle diet meals, relief of symptoms, improvement of gastric emptying, and if the patient happens to be diabetic, also glycemic control. This is a paper published this year. It's an epidemiological study. There have been probably 5 really good epidemiological studies done in the community or from national databases. And this was one such study which was published, as I said, this year. It illustrates some really quite important features. The first is the higher prevalence of gastroparesis based on this US National Claims Database, the higher prevalence in the southeast part of the country. The second is that the proportion, the prevalence of people with gastroparesis is about 270 per 100,000 persons. We'll talk very briefly about this, but the diagnosis of gastroparesis based on claims databases or medical records is not always consistently associated with physiological evidence, in other words, the gastric emptying or the finding at least of food retained in the stomach at endoscopy. So when people have used a much more stringent criterion, the prevalence may actually be about 1/10 of that 270 per 100,000. The commonest problems now in the 2017 to 2020, when this study was done, the commonest problem is now becoming the dominant type 2 diabetes associated with obesity. And that map would also be very relevant for the prevalence of obesity and type 2 diabetes in the country. I want to remind us all about iatrogenic gastroparesis. We see very few patients nowadays who've had vagotomy for peptic ulcer disease, as was mentioned earlier, but we do see some patients with gastroparesis secondary to fundoplication, bariatric surgery. Related to diabetes, remember that many drugs used by our diabetology colleagues to control glycemic control, the amylin analogs like pramlintide and the GLP-1 agonists, which we mentioned earlier before lunch, can also significantly delay gastric emptying. Now, the good news is that if you follow patients up for 12, 16, 24 weeks, if they're on a GLP-1 agonist, very often there's tachyphylaxis in the effect of the GLP-1 agonist, and so the gastroparesis does not remain a problem. But if it does, then your option is to ask your diabetology colleague to use a DPP-4 inhibitor, a dipeptidyl peptidase 4 inhibitor, which raises the endogenous GLP-1, but it doesn't have such a big pharmacological effect on the stomach. And so you get the benefit of the glycemic control without causing the gastroparesis. In the patient who's had a pancreas liver transplant for diabetes, remember that tacrolimus is good because it's related to erythromycin, it's a macrolide, and it helps the gastric emptying, whereas other anti-rejection medications will not be so innocuous. Remember also that there is no such thing as an opiate that does not delay gastric emptying. Despite everything you will read about tramadol, tapentadol, etc., the sort of minor opioids also cause impairment of gastric emptying. Let's remember that the stomach has excitatory nerves that go through cholinergic neurons to stimulate the muscle contractions, and relaxatory nerves such as nitroergic nerves that facilitate the accommodation response of the stomach. And both sides of this may result in symptoms suggestive of gastroparesis. In a study we did at Mayo Clinic with patients with gastroparesis symptoms, there was an equal split within patients who have delayed gastric emptying, impaired gastric accommodation, both problems, or neither problem. And neither problem usually means that they have more of a functional dyspepsia or hypersensitivity problem. Remember the importance, if you're going to do a gastric emptying study, please make sure you include a 3-hour or a 4-hour gastric emptying test. These are our data at Mayo Clinic using a 300 kilocalorie, 30% fat meal, and so we make sure that we have a definite diagnosis, a 4-hour being the preferred duration of the gastric emptying time. We also remember that there are other ways to measure gastric emptying, including the stable isotope breath test, which correlates quite nicely, as you can see there, compared to simultaneously performed scintigraphy. On the other hand, wireless motility capsule, which Dr. Rao mentioned, was very good and well validated for small bowel and colon, but a wireless motility capsule, a 2-centimeter large solid particle, does not empty with food, and therefore it may be retained in the stomach, and you may get a false positive result for the gastric emptying with the wireless motility capsule. Some people think that there's no relationship between the gastric emptying and the symptoms, and there are papers to suggest this. But if you do an optimal gastric emptying study, and the contrast in the top and the bottom part of this, these different slides here, or pictures, show that if you optimally measure gastric emptying, there's a good relationship with nausea and with vomiting. There's also evidence that if you improve gastric emptying, let's say by 25 minutes on the T-half for gastric emptying, you will significantly improve the patient's symptoms. And this was shown in a meta-regression that we published in Gastroenterology. Well, how do we treat the patients? Well, let's just remember the principles, the general measures. Review and eliminate medications that could be messing up the gastric emptying. What about the diet? I'll show you that a small particle diet is extremely important. Nutritional support depends upon the severity of the problem. Some patients may need a jejunal feeding tube. Some patients may need a gastric aspiration port. Pharmacologically, we still don't have medications other than metoclopramide approved by the FDA, and therefore we are moving more and more towards anti-nausea medications, the antihistamines, or not quite indicated for gastroparesis itself, but also the NK1 antagonists, for example, like aprepitant, have been used in some small studies. And finally, we're going to discuss later the procedural approaches. I just want to remind you, there is a randomized controlled trial looking at the size of particles in the meal. And from this study from the Gothenburg group in Sweden, there was evidence that if you reduce the particle size of the diet to a small size, then you will be getting an improvement in the patient's symptoms. As you see there, nausea, vomiting, fullness, bloating, all of those symptoms get better. In contrast, the controlled diet had no such benefit. There are a number of drugs that are in development or that are used off-label. I want to stress that this is all off-label treatment. 5-HT4 agonists, prucalopride is available and approved for constipation. Relamorelin is very promising. It's a ghrelin agonist, but it's not yet approved. We use off-label, especially for the hospitalized patients with retention in the stomach. Intravenous erythromycin, 3 milligrams per kilogram, is my drug of choice when the patient comes in with the stomach full of food and severe acute gastroparesis symptoms. There's evidence azithromycin also can help, and the NK1 antagonists can, if you can get the insurance companies to permit you to prescribe this, aprepitant can also help you keep the patient out of hospital. I've tried to use this a number of times to try to keep the patient from coming to the ER for IV fluids to kind of abort an episode of acute on chronic gastroparesis. I used to think that gastric electrical stimulation had really had its day until I saw this paper, which came from France. It was a multi-center study, and in the patients who have refractory vomiting, really severe vomiting, there is a large randomized controlled trial, as you can see here, 172 patients in whom there was benefit, particularly for that symptom of refractory vomiting. I want to stress the point that gastric electrical stimulation is not a pacemaker like the pacemaker of the heart. which entrains the heart, gets your sinoatrial node in shape, and therefore you get 72 beats per minute. This is really an electrical shock to the stomach. It stimulates the stomach at 12 to 21 cycles per minute. And remember, the stomach muscle usually contracts or has electrical stimulation 3 times per minute. So gastric electrical stimulation is electrical stimulation, not pacemaking. And I think in many centers, this has now been supplanted by the use of GPOM procedures. Another experimental therapy that is available is to stimulate the vagus nerve in the neck with a device that can be done after the meals. And as you can see from these studies from the San Francisco Stanford group, Linda Wynn and colleagues, there was an improvement in many of the symptoms, the aggregate score, the nausea, fullness, and bloating. And this is currently being developed. The pylorus, really, I like to think it all started when Fermin Meharin and I were fellows with Dr. Malajalada at Mayo Clinic in the mid-1980s. And we saw that among patients with so-called gastroparesis due to diabetes, a number of them had stimulation of the pylorus in the absence of distal anterior contractions. And so you see at the top of that plot, you can see the asterisk illustrating where we are with regard to the stimulation of motility of the pylorus, which you recognize by the combination of phasic events and tonic elevation of baseline pressure. The new kid on the block, as I mentioned, is pyloromyotomy. It's performed by several centers, and it's really quite safe as a procedure. And it can also be associated with measurements that we heard this morning from Dr. Pandolfino, using that same endoflip procedure to try to assess the contractility, the distensibility index, and the diameter of the pylorus. So in essence, there have been many studies. I don't expect you to see this, but effectively it's been tested in at least 10 papers from different centers, and it's been tested in diabetic, idiopathic, post-surgical, gastroparesis predominantly, and there's been improvement in patient symptoms. But one of the things that I need to point out to you is that this can be done safely, but all of these are open-label studies. And in fact, in one of the largest open-label studies from Hopkins, from Muin Kashab and his colleagues, at 12 months, most of those previous studies I showed you were at about 6 weeks to 12 weeks on average. This was a 12-month study. And at 12 months, there's 56% of patients who remain improved. Clinical success using the GCSI, Gastroparesis Cardinal Symptom Index, is improved, but it's only about 56% that are improved at 12 months. And so I think it's relevant that while we see meta-analyses suggesting improvement in symptoms and improvement in gastric emptying, we need to continue to strive to get the evidence that this really works. And this was a study that was presented in October at the European meeting, UEGW, and it showed for the first time a sham-controlled study of GPOM for gastroparesis. And I won't go through the details too much here, but to illustrate that indeed there is now sham-controlled evidence that the GPOM procedure does work for patients with gastroparesis. We are actually studying this more formally. We just submitted an abstract to DDW using the endoflip catheter to measure pyloric distensibility and diameter. And I want to make one important point, and that is that we did these studies in patients without sedation. Why is that relevant? It's relevant because if you're doing your endoscopy with propofol, which inhibits cholinergic neurons, or with fentanyl, which stimulates mu-opiate receptors cause pylorospasm. So I was always worried that when we're studying the effects of sphincters, we need to be aware of the possibility that the medications that we're using during that endoscopy could be influencing the responses that we're measuring. So up to now, we've been able to do unsedated procedures like this in 24 healthy volunteers, and we're hoping to take this to the patient data soon. I'm really stuck here. Okay. Final point I would like to make is about high-resolution manometry. So one of the reasons why I think this is relevant is that when you look at the tracings of what happens in patients with gastroparesis, you do see pylorospasm, but often you also see distal antral hypomotility. And so the big question is, if you just slit the pylorus, are you really resolving the problem of the neuromuscular apparatus, which is not working well? So what we do routinely when we do this procedure is place a probe in the upper GI tract. You can see on the fluoroscopic imaging, I have 13 sensors across the anteropyloroduodenal junction, place the wire into the small intestine, and then I can put my tube very effectively into the small intestine. And when I do that, I'm able to get a much more thorough assessment using high-resolution manometry of the distal antral contractions, and which you can see on that left side, very few contractions in the postprandial period, less than 5 actual contractions of the antrum in a 20-minute period of time. And on the other hand, during the second postprandial hour, you can see the other example where you see a great deal of pyloric contractility. Important to have that many manometric sensors because the location of the pylorus is going to change with the change of shape and starting of emptying of the stomach. So this gives us a much more thorough assessment of the anteropyloroduodenal coordination. Special considerations, just one slide on small bowel dysmotility. First of all, remember that often patients with gastroparesis may also have small intestinal dysmotility. For instance, in patients who have diabetic neuropathy, scleroderma, or amyloidosis. If you find dilated loops of intestine, it's more likely to be a myopathic disorder. If you have a myopathic disorder, you're more likely to have bacterial overgrowth, more likely to need, unfortunately, a loop ileostomy to try to help things come through the small intestine. And those patients are more likely to require enterofeeding. And on the right side, I'm just showing you a small bowel manometry showing virtually no contractions over a long period of time. So in summary, the conclusions are the first-line treatments in patients with gastroparesis. Make sure we get a good gastric emptying study, exclude iatrogenic disease. Remember to exclude what Dr. Rao was showing earlier, the rectal evacuation disorders, which sometimes can also be associated with delayed gastric emptying. Diet and nutrition, remember to blenderize the diet and cook it. Prokinetics as much as possible. Antiemetics to relief of symptoms. GPOM, I think, is a very important addition to our armamentarium for treatment. I think we need to individualize, this may be a theme that keeps coming through, individualized treatment. And I think high-resolution manometry can help us to do that, and endoflip examinations, hopefully, in the future. Conclusions, in patients with small bowel dysmotility, I really manage the patients just as I would gastroparesis, but if you have dilatation, think this is myopathy. This patient is more likely to have small intestinal bacterial overgrowth and may require more support for nutrition or possibly also placement of tubes for decompression and for enteral feeding. Thank you very much for your attention.
Thank you very much, Michael. So it's always difficult for me to introduce our next speaker, David Johnson. He's been one of my very best friends for a very, very long time. He's also responsible for my alcoholic liver disease due to our excessive wine tasting, but we'll go into that on another occasion. David is a professor of medicine and director of the Division of Gastroenterology and Hepatology at Eastern Virginia School of Medicine in Norfolk. He has one of the broadest knowledge ranges within GI of anybody that I know, and I could literally ask him to talk about anything. One of his passions in the recent most past has been the gut biome. So I've asked him to come up and update us on the status of the gut biome. It seems like it's responsible for everything that's happening with us in GI, but I'm sure he'll set us straight and let us know about that. So welcome, David.
Thanks, Rob, for the most kind introduction, and hopefully the movie is as good as the book. We'll wait and see. But the gut microbiome is certainly in the news, right? You can't pick up a journal, you can't pick up an article anywhere that doesn't attest that the microbiome is the answer, and we see this virtually across all specialties. But is it really the answer, and are we really there, or is it something that we're just starting to understand, maybe what we don't know? conflict of interest here is really just to outline in concept of my discussions today. What I wanted to do with you is to just spend the next 15 minutes and talk about first, what is the definition of the gut microbiome? What does it really mean? What are the alterations, and how do you change the gut microbiome? What are the implications? It starts to make sense when we start to look at studies. It's critical to understand what these alterations are, because there's tremendous amount of variation across these studies, not only in how they were done, how they were collected, but the tests themselves and the interpretation of these tests. And what these variances are important to understand when we start to then jump out and apply our new knowledge to really mitigating disease states. And what are the disease states that really are front and center for gastroenterologists that we may be looking to on the near term? It's very expansive. If you think that you start at the esophagus and you end at the rectum, there's virtually nothing in between. But I want to touch on some very common things like obesity and aging, and in particular, we'll talk about something as it relates to youthful thinking, and at the end, we'll put that in perspective. And I want to leave you there in the idea of we know a lot, but give you some direction and wisdom as we finalize where do we go from here. Well, defining the gut microbiome, there are a variety of microbiomes, microbes that are really in the composite, but it ranges not just from bacteria, which I think is a parochial thinking. It's really bacteria, fungi, mostly yeast, viruses, and phages, but the collection then is called the microbiota, and the genes are called the microbiome. So there's a lot of terms that are used interchangeably, but not absolutely correctly. The misconceptions that I think most clinicians would have, number one, is that all laboratory and computational methods are the same, and that's clearly not the case, and there's tremendous variance across this. So if you start testing with different modalities, you're going to get different results. Secondly is that one shoe does not fit all. We all have 2 feet, but that doesn't mean we have the same microbiome. And so a core microbiome for each and every one of us doesn't necessarily reflect that. And in fact, your microbiome is changing right as we speak. And I'll show you how that changes in day-to-day variance just from the concept of where you are in a given time of the day. This second is that it's stable. It doesn't change. Well, there's very rapid change, and it relates to what you had for lunch, what medications you may have taken, disease states, excretion rates, time of the day, sleep, how you slept last night, and variances based on age. This comes from a study that we just published a couple weeks ago, actually in Life, looking at the effect in mice on the microbiome changes relative to sleep fragmentation. Mice are daytime sleepers and nocturnal activity, so we disrupted the sleep cycle in light and day, and then we used a control variance here. And we then looked at the microbiome. In normal, what happens, you start here and you finish here. But as you can see, you undulate through the course of the day, and your biome's not static. It changes. There are a variety of things you do. You excrete, you move. There are a variety of things that change, but your biome is changing constantly. When you change the sleep pattern, the microbiome goes exactly crazy. And if you look at both the disrupted sleep patterns, they actually change and invert. So the biome of when you change and check through the course of a day is going to make a big difference. And how you slept even the night before is going to make a difference as far as the testing. Well, aging affects a lot of things, right? And in particular, the biome of aging, it really is something that's increasingly cognizant as to it does have a real effect. Looking at this paper that just came out in Cell Reports, this is a concept of as we go from our teens to our 80s, there is a change in particular as it relates to diversity. The alpha diversity of the microbiome changes. There's a change as it relates to composite facultative anaerobes, and these seem to increase, and these are things that have negative effects. And there are factors that affect the duodenal integrity as well. As we age, we have an increasing number of conditions as we certainly accumulate diseases and medications composite with that. But these are associated then with changes in duodenal diversity, and these are changes that are evident in elderly patients, combinations of chronic aging, a number of the diseases, medications, but these also change as it relates particularly to coliform species in a highly significant fashion relative to just a general comment, but the biome of aging clearly makes a difference. Dr. Camilleri is an expert in so many things, but I think a very brilliant article that's yet in press, still in Gut, coming out in the next couple months. He talks about the change in the gut, and it relates to the biome as it relates to good guys and bad guys, not so much using that term, but microbes that enhance the gut barrier, and there are a variety of these that are, again, evidence that these are good things. As they reduce, they enhance the gut bacteria, and then there's a composite of augmentation of things that decrease gut integrity, and these are factors that play into day-to-day activity as it relates to the term leaky gut. And again, these battle. There are variances that change over the course of the day, variety of things that change in your day-to-day activities, diet, etc. But it's a barrier building as it relates to the gut bacteria, and there are good guys and bad guys. And the term leaky gut is really much I think a bad term, but it really enhances understanding that we have translocation of things that really aren't supposed to be moving out of the gut. And regardless of how you get there, by a variety of things, the gut microbiome is somewhat of a protector, as I just alluded to. You can have the gut working for you and the bacteria enhance the gut integrity, or you can change the microbiome and change that. And it really is something that is not necessarily just on the surface. It may be in the basement. So a transmural stimulation of cytokines that drive inflammation pathways and enhance permeability. So it's the gut microbiome, not just on the surface, but the interaction with the surface and driving cytokine and chemokine-related consequences of gut permeability and inflammation. This does change also when the microbiome communicates with the brain. So the brain-gut axis is very much involved as it relates to the microbiome, and this is through a variety of chemokines and cytokines, and in particular playing a very prevalent role here is the degradation products of microbiome, in particular short-chain fatty acids, and I'll show you how that plays out in a bit. But a variety of things that affect neurotransmission, in particular proteins with signaling properties, both in the CNS and the peripheral gut. And again, these are things that are driven by microbiome and the balance through these. There are brain-derived neurotropic factors as well, and also interplaying with the hypothalamus and the pituitary axis, in particular driven through the cortisol production pathways. And this is implicated as you start to think about depression and brain-gut interactions for a lot of our functional diseases. The new concept of reflux disease is one that's very much a focus of my interest at present time. And this really comes from the really seminal work from Stu Speckman and Rhonda Souza. And they published this back in JAMA. And the traditional nature of reflux disease, it's acid on the mucosa that causes injury, right? Well, what they showed was if the acid is causing the injury, that should be where the mucosal disruption is. And that's not, in fact, what they demonstrated. It was inflammation that led to a cytokine response, and the cytokine response was independent necessarily of where the acid was, and the mucosal disruption occurred as a function of the upward regulation of the cytokine implications to the mucosa. So these areas of surface erosion wasn't necessarily where the acid was, but the immune response was hyperregulated and leads to the changing of the peptic esophagitis. And it led Peter Karillis, who wrote the editorial on this, to say that it was really turning the pathogenesis of acute peptic esophagitis inside out. We're talking about water in the basement, not necessarily the rain on the roof as far as the disruptors going forward. This comes from a review article that we just published looking at esophageal diseases and particular implications for microbial changes in the esophagus now. We talk a lot about gut microbial changes. In the esophagus, there's growing information about instability as it relates to not only reflux disease, but Barrett's, esophageal adenocarcinoma, and even squamous carcinoma, and also an area of eosinophilic esophagitis, all burgeoning new hypotheses, but data support there is imbalance that may play a pathogenic role. As it relates to celiac disease, moving into the small bowel, the microbiome plays a key role as it relates to T cell function and CD4 helper cells. And in fact, this is said to trigger then this mucosa-associated change that we know is celiac disease. And this, we think, at least there's seminal evidence now that suggests there may be microbial changes that open the key. 1% of the U.S. population has a gene for celiac disease, but not everybody gets celiac disease. So there's a trigger there. And this seems to be more and more at least suggested that there may be some microbial reason for this instability, and the lock and the key then becomes necessary that you have the genetic predisposition, but there are a variety of cofactors that then accumulate and can be the original trigger. So the original trigger can come from microbial changes, additional things as it relates to diet. Moving into our next speakers, the irritable bowel type discussions, I wanted to put some factors as it relates to irritable bowel in the microbiome. The classic infection as it relates to microbial changes in the irritable bowel is post-infectious, right? So you can ascribe this to however you got there, from protozoal or bacterial or viral-related causes. There are changes that you can see, and there's dysbiosis that associates with protease production. That disrupts the gut right there. But there are also things that change with increased changes from cytokine. It relates to cytokine and chemokine-related changes in permeability. This relates to immune dysregulation, and then also a variety of things that relate to the submucosal neurologic changes and serotonergic dysregulation. Again, tying these things into much more of the functional diseases that we would now say may have a very strong microbial association. As it relates to irritable bowel as well, it's not just the bacteria, but what the bacteria produce that may also be a significant component. So it's not just the composition of what's there, but what they produce. And there's a taxonomic diversity of the bowel as it relates to normal. But it's not so much what's there, but what they may be metabolizing. And again, getting into short-chain fatty acids. So the microbial changes that lead to biologic microbial functional changes are really where this is headed. These are particularly related to the short-chain fatty acids associated here with irritable bowel and the constipation predominant or diarrhea predominant. There are these short-chain fatty acids that are derivatives as it relates to microbial metabolism. So again, when we get into the world of microbiome and irritable bowel, we start with the idea that there are tremendous things that can influence the environment around us, and these can also then play into the host. It changes the microbial changes, and then there's this interaction between short-chain fatty acids back and forth between the host, and then the host influencing, again, the microbiome. So, again, much more complicated than just a certain pedigree in the small bowel as it relates to irritable bowel. This comes from a very provocative work. This is coming out in a couple months in Gut from Dr. Vevier and colleagues from the United Kingdom. But what they did is they looked at two subtypes of patients, in particular irritable bowel. One they called the normative, and this was something that they ascribed relative to not different than the control, the household controls. But they then identified a pathogenic microbial change. It was just different. So they had a pathogenic and a normative, and what they found there were differences in the pathogenic group that related to changes in firmicutes genes and carbohydrate and amino acid metabolism, and then changes in Bacteroides. But again, a pedigree, if you will, that they called pathologic. And the reason that was important, when they looked at then application of a FODMAP diet, this is the fermentable oligodisaccharide, monosaccharide, and phenols diet, there was a significant prediction of those people that had this pathogenic microbial change that actually were responsive. So they were able to pedigree who was going to respond based on what they could see in the microbiome. And again, when they did the FODMAP diet for this second group, they were actually able to normalize this. So the FODMAP diet was, again, figuring here to renormalize the microbiome, and a clinical response was predictive based on this. As it relates to inflammatory bowel disease, there's a tremendous interest. Clearly, the microbial changes in IBD are very evident. We just don't know what they really mean. And in particular, there's a balance as it relates to the normal of healthy, but when we get to inflammatory bowel disease, there are bacteria that go down, there's some that go up. But the point here is that there's an imbalance, and there's a tremendous effort to try and make this really work. We've seen trials on fecal transplant, a variety of things. We know antibiotics work, right? We give Cipro and Flagyl when we start patients in Crohn's disease a lot of times, and we see some improvement with that. But emphasizing this is in trying to put this in perspective is an article that just came out in Gut as well, looking at micro changes. There's a tremendous diversity, but it varies so frequently, and it changes with temporal stability, time of day. A lot of these things are not predictable, and it becomes very difficult to, again, get the one shoe fits all as we start to talk about microbial changes and mitigation strategies for IBD. As it relates to colorectal cancer, there's some very interesting information here, and it relates to decreases in bacteria that ferment fiber, and this gets, again, to the short-chain fatty acids, a variety of increases and decreases, but there are also things that initiate bacterial-related consequences towards cancer with E. coli and colobactin toxin that promotes this proliferative DNA change. There's a promotion of B. fragilis through fragilis and changing T cell helper cell, which is a pro-carcinogenic. And then there are progression of things, again, led by Fusobacter, in particular to E. cadherin, and these promote not only proliferation but invasion. Again, all these things now new news as it relates to cancer. And then in the biome change as it relates to cancer, it may be not just the biome was abnormal, but it's what you fed your biome. And this comes from very interesting information, an article in Press with looking at the effects of the sulfur diet. This is something that comes a lot of processed foods and processed meats in particular, but early association with early colorectal neoplasia. So it's not so much that you changed the bacteria, but you gave the bacteria something that was caustic to whatever the normative process is, and they produce things that were potentially toxic. In this case, hydrogen sulfide, which is a well-recognized gastrointestinal carcinogen. So these sulfur metabolizing bacteria, these are evident in particular as you start to cultivate the exposure for what younger people have eaten. And we see that now there's an association with adenomas and advanced adenomas in this sulfur type of high sulfur producing bacteria. But again, normative bacteria that just got fed something that potentially was used to be toxic. So the bacteria actually can have oncogenic properties too. And we've seen this in a variety of tumors where they can actually remodel and change the microbial changes around them based on degradation products, and this affects mucosal integrity and immune response. Just a brief word, you heard so many great things on liver this morning, but the liver is not immune from, as it relates to the microbial changes either. It's a delicate balance. The liver has tremendous advantage for normal process, but again, the microbiome works to inactivate or hold harmless a variety of antigens that are all introduced through the gut. And microbial dysbiosis and liver disease, the topics are just expanding. It affects so many patients when you start to talk about the prevalence of fatty liver disease, alcoholic liver disease, sclerosing cholangitis, autoimmune disease. We're just beginning in that area. Obesity affects 60% of the U.S. population. The microbial changes in obesity clearly are also very, very much a hot topic. Microbial diversity actually shows a preventive effect. So the more diverse your bacteria are, you actually can prevent this. And we've seen this in long-term and in longitudinal studies in healthy individuals. But westernization of the diet, the processed diet, 33% of the U.S. population takes one or more processed foods a day. And again, reversal of the diversity changes and predisposes to some of the things that are consequences. Multiple factors, as we talk about, though, are related to this, and dysbiosis, again, is associated with weight gain and obesity, but this is a two-way street. You can have this go in a positive or a negative way. You see tremendous changes in gut bacteria after gastric bypass, a variety of things we already talked about, diet, physical activity, sleep-related effects, medications, and bariatric surgery, among many things, but this is still an area of hot interest given the prevalence of obesity. It would not be 2021 without a concept of measuring COVID. Well, microbial diversity in fecal samples has decreased. This comes from a review article that we just published, and in particular also looking at an article in Press in gastroenterology. But there is a tremendous diversity change as it relates to COVID, in particular closely related to the severity of COVID. Recognized 40% of the U.S. population, the population with COVID, has GI-related symptoms. Diarrhea may be a predisposing symptom in 40% of the time. But this prolonged dysbiosis, despite the clearance of COVID, is well now recognized, and it may contribute to persistent illnesses and secondary changes as it relates to bacterial pathogens and reduction in beneficial commensals. And what we've reviewed in this most recent review is looking at the long-haul COVID, and this is something that we see affecting 40% of the patients with COVID at present day. Well, we talked about aging and the gut microbiome. Maybe the gut microbiome may be our fountain of youth, and not to steal the thunder from Dr. Pardee, who's going to talk to you about fecal transplant at the end of the day, but age triggers lots of things, and metabolic disarray and immune disarray certainly is something that can accumulate over time. There's a perturbation as it relates not only to the immune function, but also brain function and behavior. We see this on a cognitive basis. You can see it on anatomic basis, in particular in the hippocampus. And the gut bacteria undergoes this community shift just with time for all the reasons that we talked about. And these are associated with frailty and cognitive changes. And this is a very provocative study that was just published, and they took young mice and old mice, and they did a FMT, a fecal microbial transfer from young mice into aged mice. I won't tell you where old is. Rob and I change that definition every year. But the gut microbial change is evident when you took the stool from the young mice and put it in the old mice. Lo and behold, the young mice bacteria became the old bacteria, and they were durable in the older mice. There were hippocampal changes. They were evident when they did the histologic sacrifice on these, and they were chemically more similar again to the youthful mice. And they then did some task on this, in particular sensory changes and cognitive changes, in particular maze evacuation, and they were able to perform more proficiently. You ask, what's the take-home message on this? Well, the take-home message is be nice to your kids. So where we leave this is the microbiome. Are we really there? And clearly, I think we can summarize by saying the microbial studies have been enormously valuable. We've got tremendous new understanding as it relates to mechanistic disease, particularly from animal models. We've got descriptive evidence as it relates to human disease associations. And where there's been explosive interest, that would certainly be an understatement. And what I think we have is provocative suggestions for changes and solutions. Again, where are we headed on this? Well, it's important to recognize there's a tremendous bias on identification, the assays, how the studies were done, and it's very important before we jump to conclusions and try and jump to mitigation strategies to understand the limitations before we launch applications, in particular in trying to remediate disease. So when we talk about looking at launching and new wisdom and understanding, I'll leave you with two thoughts. One is the launch applications. We've seen so many things that are so exciting. You just want to jump and launch, and you want to get there quickly. And this comes from the recent launch on SpaceX. The cockpit was actually able to communicate back to the Space Control Center, and they said, so we're off. We're moving fast. Does anybody know where we're going? I think that pretty much summarizes the microbial changes, and in particular then taking that forward into looking at understanding where are we and what do we have in wisdom. To go back to ancient times of Socrates, Socrates says the key to true wisdom is recognizing that you know nothing. And I wouldn't say that we know nothing, but I think we're getting smart enough to ask good questions. And what does that mean? Well, it makes me wonder. And the wonder of what Socrates said is actually the beginning of wisdom. So I wonder if we can take these applications of good questions and really apply them to really the exponential possibilities for microbial changes in disease management for our patients. Thank you very much.
Wow. Fantastic information, David, and very provocative. So we'll ask Michael Camilleri now to come back up and talk about something that I'm sure he's never seen before, which is abdominal pain. Nothing seems to work. Welcome, Michael.
Thank you again, and thanks for the introduction and for the opportunity to be with you. It's difficult to follow that, David, but I'll try. So my objectives are to go through very briefly some of the systematic reviews and meta-analyses of drugs for pain in IBS. I'm going to talk about some single-center studies that appear to be quite promising with novel approaches. We'll talk about cognitive, behavioral, and other brain-directed therapies for which there is increasing evidence, including mindfulness. And if anybody wants to read this in greater detail, this paper's just been published on the 20th, of November, just about a week ago. So this is from a review article that I wrote for JAMA earlier this year, and basically it reminds us that when we're dealing with patients with irritable bowel syndrome, we often will focus on the bowel dysfunction, and we have good treatments, and Dr. Rao explained particularly the constipation side. We have good treatments for the diarrhea side. My objective is to focus entirely on the pain side, the left side of that slide. And we know that the first-line therapies are diet, exercise, psychotherapy, antispasmodics, neuromodulators, and alternative medicine. And when the patient does not have success, or we don't have success in helping the patient rather, then you try an alternative neuromodulator, cognitive behavioral therapy, or hypnotherapy. But does any of that really work? Let's look at the evidence. So first of all, high-fiber diet, low-FODMAP diet, probiotics, and rifaximin. This is a summary of very fast literature. And there's a lot of detail on this slide, so I'm going to try to paraphrase. So high fiber diet is good for constipation. And if you look at a systematic review and meta-analysis by Alex Ford, Nick Talley, etc., there was an evidence of improvement of abdominal pain with a high fiber diet. The low FODMAP diets, again, you'll find some evidence from systematic review and meta-analysis for pain. But there was a very nice study again from the Scandinavian group that showed that a traditional dietary advice would be given by a dietitian that works with you perhaps in the clinic, avoiding certain types of foods that may be stimulating the symptoms. It works just about as well as a low FODMAP diet. Probiotics, again, systematic review, meta-analysis, 15 trials, somewhat favorable results, and more recently, a study suggesting that this may be entirely strain dependent. So it all depends upon whether your favorite bug is in the probiotic preparation that you happen to give to the patient. What about rifaximin? Well, rifaximin, large studies approved by the FDA, New England Journal paper, etc. I've always been impressed by the effects on bloating rather than the general effects on abdominal pain. But there is some improvement of abdominal pain. Guy Bogstans and I summarized the literature a few years ago, and I'm going to give you a little bit of an update on this. But we have the diet, probiotics, antibiotics, rifaximin, antispasmodics, antidepressants, and then drugs targeting specific GI receptors like 5-HT3 antagonists and GCC agonists. So let's look at this in just a little bit more detail. The antispasmodics. So the first thing I'll ask you to look at is that left column. And the only antispasmodic we have available in the United States is hyoscine or hyoscyamine. The drugs otilonium, pinavarium, simatropium, very good randomized controlled trials in the literature, all approved in Europe, but none available to us. So let's think about it, that hyoscine or hyoscyamine may be something that we could use, and I'll tell you how I actually use that in the context of pain. Peppermint oil. The old preparations, there were trials many years ago, and systematic review meta-analysis shows efficacy for global symptoms and perhaps also for pain. Sustained release formulation is now available, and Bruce Cash had a paper on this in a randomized controlled trial, and there is some evidence that peppermint oil could also be beneficial. The delayed release preparation is perhaps less effective than the original preparation. Antidepressants, I'm going to spend a bit of time on this because they are used extensively in the practice of irritable bowel or chronic abdominal pain. And with antidepressants, we have to also think about cognitive behavior and other brain-directed therapies. And I'm going to show you a little bit more details about the general efficacy of the antidepressants. And I'm afraid we need to look at the details of these studies. If you look at the 2018 monograph from the ACG on antidepressants for pain from irritable bowel syndrome, they came to the conclusion that the number needed to treat was only 4, which is wonderful if it was true. You know, I'll contrast that with, let's say, allocetrone or other medications for irritable bowel syndrome, where the number needed to treat is closer to 9 or 7 to 10. So in essence, let's look at some of the... Whoa. Did I say something wrong?
You said something very profound.
So if you look at the antidepressants, I'm going to show you a couple of points when I look at these forest plots. Always look at that line that's going vertically down and see how do the individual studies actually differentiate themselves from that line, because that line tells you that the drug is no better than placebo. And if you look at that rather busy slide for overall efficacy, I just want to point out the largest study ever done with antidepressants by Doug Drossman, it's just about in the middle of that sequence of studies, was actually not significant for disipramine compared to placebo. Overall, if you look at the diamond at the end, it's positive, but it's really a large number of relatively small studies. The overall efficacy for SSRIs is also significant, but again, most of the studies actually were not. Adverse effects with tricyclics, obviously, we can get constipation, we can get other problems, and as we can see also with SSRIs, there is a lower risk of adverse effects, whereas with antidepressants of the tricyclic group, there's a greater risk of adverse effects, so the meta-analysis favors placebo. Now, if we actually look at abdominal pain, there is abdominal pain as an endpoint in a few studies. And again, I'm a stickler for detail, but if you actually look at the details for some of these studies, for instance, that study that you could see from Vahedi, that was a study which was performed in the Middle East, and the interesting thing for me was that the active treatment arm, the tricyclic, had an 80%. I've never seen an IBS study with 80% efficacy. And the placebo arm had 10% efficacy. I've never seen an IBS study with placebo of 10%. So again, the data, when you look at a forest plot like this, be careful. You got to look at the details. And essentially, yes, there is a benefit for abdominal pain, but of course, that is with the tricyclics, but not by the SSRIs. I'm going to talk a little bit about opioid agents and novel uses of linaclotide. And in this section, most of the data are from single center or phase 2b studies. What about opioid agents? Where 3 classes of drugs have been tested. Loperamide, which is great for the diarrhea. Acetaminophen, which is not approved, it's a kappa opioid agonist. And then elaxadoline, which is a combination opioid agonist and antagonist, and it is approved by the FDA for IBS-D. And as you can see, overall, there is benefit, but the most relevant data, I think, are with elaxadoline, which you see here. The studies from Tony Lembo show that there is benefit in the 2 big trials. But again, just to remind you how to calculate the number needed to treat, you take the average of, let's say, 28.9 and 29.6 in trial 3002, and let's say that's 29%. And with placebo, it was 16%. So the delta is 13. 13 into 100 is about 7.5. So the number needed to treat with elaxadoline is 7.5 people. What that tells me is that for every 7.5 or 8 people that I treat, I have a great chance of getting 1 to improve. And that's, I think, a relevant, important way to look at the data. The other way to look at this is you look at the actual plot on the right for the worst abdominal pain, and you see the difference there is about 8%. 8 into 100 is 12.5, so I'm not too far when I do that calculation. Linaclotide, these are data from Lin Chang showing improvement in the severity of abdominal pain and also in the improvement of bloating, discomfort, and pain, as you can see there in terms of the delta. And of course, you always see in the patients with IBS, you're going to see an improvement with placebo. These are very interesting new compounds that are colonic release preparations of linaclotide. The idea here is, for basic science, has shown that linaclotide reduces sensation mechanisms, I won't bother with the details, arising in the mucosa and that are being transferred to the spinal cord and to the brain. And so what they did here was they developed preparations that release the linaclotide into the colon so it doesn't cause the diarrhea. And in fact, there was no diarrhea with these 2 preparations. And Bill Che's data here suggests that there is an improvement with these new uses of linaclotide. Really experimental, histamine H1 antagonist, NK2 antagonist, and the available medication, off-label use, pregabalin. So very briefly, Guy Bokstans and colleagues in Leuven in Belgium show that a histamine H1 receptor antagonist, which is a non-sedating, just like we have many such preparations that we use for allergies in the United States, right? And these H1 antagonists are able to reduce pain-modulating receptors like TRPV1. And if you look at the right lower quadrant of that slide, you'll see the improvement relative to placebo for both the abdominal pain subjects global assessment as well as several quality of life indices. Just to remind you, NK1 and NK2 receptors are located on the visceral afferents, as shown in this cartoon. And in a randomized controlled trial, Jan Tak led the study, mostly in Europe, that showed there was an improvement in the greater number of responders for 75% of the 12-week studies, which occurred in females but not in males. And this was occurring also with an improvement in stool consistency. Pregabalin. You know, this is an approved drug for the treatment of fibromyalgia and other forms of pain. And my colleague Yuri Saito at Mayo Clinic led a single-center study of pregabalin in irritable bowel syndrome. And to cut a long story short, you see on the right side that the visual analog scale for IBS pain was improved compared to with placebo. Again, the delta is about 17% on the visual analog scale. It's not quite a responder definition, but it seems quite promising. In the study, Yuri used a dose of 225 milligrams of pregabalin compared to placebo. And you can probably tell that that's a fairly high dose of pregabalin. It's got some sedating effects and may have some central effects as well. So, but the point, I think, is that there is proof of principle that this mechanism might be beneficial. I'm going to very briefly touch upon opportunities on brain-gut interactions and brain-gut behavior therapy. And there was, for people who are interested, there's a great review published by the Rome working team on the different types, self-management, cognitive behavioral therapy, gut-directed hypnotherapy, mindfulness, and psychodynamic interpersonal psychotherapy. As I said, I'm not an expert in this area, but there are several studies on psychotherapy. I actually got into trouble with my friends in the behavioral psychology world because in my overview in JAMA earlier this year, I actually used an assessment of the evidence in the literature, and I said that overall the evidence so far does not show psychological treatment to be effective in relieving symptoms of IBS. And I can't tell you how many messages I got. But, you know, I was really trying to analyze the literature, the systematic reviews and meta-analysis, the data pooled from several randomized controlled trials. Alex Ford and his group did a lot of these meta-analyses, and they were really concerned about methodological concerns, significant heterogeneity, funnel plot asymmetry, which suggests publication bias, and also problems with trial design, etc. So the point is that, yes, there is some evidence of efficacy, and we need some more therapy. When you look at cognitive behavioral therapy, it's really quite significant. There's self-monitoring, patient education, muscle relaxation, cognitive restructuring, flexible problem solving, modifying core beliefs, and relapse prevention. Whenever I see such an intense intervention, you also start to wonder about the placebo effect of that intense intervention. And so when you look at these types of randomized controlled trial, Jeff Lackner and colleagues in Buffalo, New York, did a study comparing intensive cognitive behavioral therapy versus minimal contact cognitive behavioral therapy versus just education. And you can see that there is particularly benefit of cognitive behavioral therapy compared to just education alone, and that the minimal contact was actually just as good as the intensive treatments with cognitive behavioral therapy in the clinic. We don't have time to go through this, but if anybody wants to look at a meta-analysis, I always look at the diamonds at the bottom. If they're crossing the line, it tells me that hypnotherapy may be better than some other types of treatments. Is it cost effective? Another study from Jeff Lackner's group recently showed that if you do minimal contact versus standard cognitive behavioral therapy, it's obviously cost effective to use minimal contact. Mindfulness is another component of the brain-directed therapies for irritable bowel pain, and there are certain aspects of mindfulness that appear to be predictive of responsiveness. And I'm not an expert in this area, but from this paper, it suggests that the change in the act with awareness in terms of mindfulness seems to be a predictor of responsiveness. And I want to leave you with a vignette. So this is a patient who had 6 or 7 admissions to hospital because of severe abdominal pain. And I tried to get one of my favorite journals to accept a title, which I wanted to call Purple Pain from Minnesota. And you can understand why I wanted to do that when you realize, of course, that Purple Rain came from Prince. But what we had was a patient who turns out, please, I can't lose my punchline. Can you advance the slide? Yes. So this patient, it turns out, had acute intermittent porphyria. And this was at the 6th hospitalization. 2 of those hospitalizations were at a rather well-known center in the Midwest. And eventually, the penny dropped when a nurse said, there's a really funny change in the color of this patient's urine. The urine was being sent to the lab for urine analysis. And thankfully, the house staff listened to the nurse, and the nurse actually helped us make the diagnosis. So remember, even though the patient may have chronic pain, there may be a reason, it's rare, but if we don't think about it, we'll never diagnose it. So I leave you with some hope, and my conclusions are, some things do work, we have to select carefully. Among the drugs approved for IBS, linaclotide has been shown to reduce pain in IBS with constipation. Elaxadiline helps for the pain for IBS with diarrhea. Antidepressants and neuromodulators, certainly for the diarrhea-predominant IBS, tricyclics are a good thing. Antispasmodics, I use them routinely, sublingual, 0.125 milligrams, at least 2 or 3 times a day for acute episodes of pain. I tell patients to space them out with at least 8 hours. Remember pregabalin. But unlike the clinical trial, which started at 225 milligrams twice a day, I start with 25 milligrams twice a day. I rarely, if ever, need to go higher than 50 milligrams twice a day. Drugs in development, maybe non-sedating antihistaminics, novel formulations of linaclotide, and remember to work with our psychotherapy colleagues for cognitive behavioral therapy, clinical or home-based. I do believe that this could be very helpful for our patients. I'd love to see more data. Thank you very much again.
Okay, so Dr. Kovali will now present some cases and see if we can tease out some of the wisdom from our panel here. So if we could have Dr. Kovali's slides.
Okay, I'm not going to send you any doozies. These are general GI cases that we all see in our common day in clinic. Uh-oh, there it goes. So first case number 1, 39-year-old white female presents with severe constipation and abdominal pain for the past 15 years. She reports having one bowel movement every 5 to 7 days. She has intense abdominal cramping that is alleviated with a bowel movement. And she also has excessive straining and feels like she cannot completely evacuate her bowel movement. She has failed multiple attempts with over-the-counter laxatives before coming to our clinic. She's tried PEG, bisacodyl, Senna. She also failed trials of lubiprostone and linaclotide. Her past medical history is significant for endometriosis and GERD. Her past surgical history is significant for a laparoscopic cholecystectomy. Her family history and social history, non-contributory. She's not a smoker, no illicit drug use. These are her current medications. Physical exam. She's thin white female. Abdominal exam is benign. Rectal exam, this was for Dr. Rao, but normal. Anocutaneous reflex. Normal resting sphincter tone. No masses are palpated. No stool in the rectal vault. And upon bearing down, she has abnormal perineal descent. Labs, including thyroid function studies, celiac serologies, were normal. And before coming to our office, she already had a CAT scan of the abdomen and pelvis, which were normal. And the endoscopies were done, colonoscopy, EGD were normal, including biopsies for celiac and H. pylori. So the first question was, and I will tell you that Dr. Rao presented a similar case, and he had a beautiful slide, but given prior failures of osmotic, stimulant, and secretory laxatives, are any additional investigations warranted? And I'm going to go to the next slide because of time. So she did undergo a SITS marker study, and she basically had 24 markers noted throughout the colon on day 5, predominantly left colon. Large stool burden was noted. On MR echography, she does have a small anterior rectocele, but otherwise essentially normal. And anal rectal manometry was performed and did confirm severe type 4 dyssynergia, and she's not able to expel the balloon. Oh, I see what you're saying. So basically, let's focus on the first question, but where would you go next? What treatment option would you go with this patient?
Was she taking her PPI daily?
She was.
I'm just kidding.
Yeah. She was. I know. Oh, no.
Oh, here. I really don't think she needs any new medication. She just needs what Dr. Rao was recommending, and that is to refer the patient for pelvic floor retraining with biofeedback.
And just to move on to the next case, she was referred to pelvic floor physical therapy, and we maximized Miralax, and she did well with overtime.
Again, if there are any questions from the audience,
Yeah.
please get up to a microphone and we'll answer them.
Can I just make one point? Whenever somebody has an abdominal X-ray or a CT scan, look at the coronal images. Look how much stool burden there is, and see whether you see a gas bubble in the pelvis. We've actually published data that suggests that if the size of the gas bubble in the pelvis is greater than 9 square centimeters, even before you've done your rectal exam, there's a 70% likelihood that they have an evacuation disorder. So that's like a simple corroborative bit of evidence that you can pick up from the CT scan done typically by somebody else.
So one thing, just Michael taught me this a couple, 2 or 3 years ago in a patient we interacted with, the hypermotility that you see with some of the joint related and defecatory disorders. Do you want to make a comment on some of the data that you've actually really published on this, but under-recognized as far as, Ehlers-Danlos and that type of kind of person that you view as chronic constipation, but if you don't take the right history, you may miss this entirely.
So Ehlers-Danlos syndromes and hypermobility type syndromes are associated with either excessive perineal descent, so that is something I would look for. This patient did not have excessive perineal descent, so that was a good sign. But, they really are predisposed to having defecatory dysfunction because the dynamics of opening the rectoanal angle is not maintained properly. And so the force kind of goes down into the perineum and drops the perineum, but it doesn't help the stool get around the rectoanal angle. That's the best way I can explain it. But look out for it because it may require, more therapy. And people like Qasim Aziz and colleagues in London and England actually brought first attention to that condition.
And my point for raising it is it's not something that a gastroenterologist would think about when you take a chronic constipation history. And I clearly, I missed it. He didn't. Darn it, Mike.
Hey, I got it right once.
Okay. So this is a 55-year-old female who presented to our clinic with abdominal pain, early satiety, nausea, and vomiting for a year. Her symptoms began after a protracted upper respiratory viral syndrome that started in December of 2019. Her pain is located particularly in the mid-epigastric region. It does radiate to the back. It occurs 30 minutes after eating, and she just can't eat. She eats several bites, and she's full. It is associated with nausea, and she is vomiting. She has lost 19 pounds. She continues to lose weight. She can't keep weight on, but her bowel regimen hasn't changed. Past medical history is significant for, it's GERD and asthma. Past surgical history, she's already had her gallbladder removed. Social history and family history are non-contributory. Medications include Protonics and Advair. She's still taking her Protonics. On physical exam, she's underweight, white female. Her abdominal exam is benign. Essentially, the physical exam is benign. Labs, including thyroid studies, celiac studies, are normal. Imaging does include a CT, abdomen and pelvis with contrast, which is normal. She had an upper GI series with small bowel follow-through, which was normal, and abdominal ultrasound, all normal. Before coming to our clinic, she had an upper endoscopy, which was essentially normal, and the gastric emptying study was stated as normal, although when she came into clinic, she says, I can't complete the study. I can only take a couple of bites of the eggs and cannot do it, and I cannot go back. What would be your next step in management?
So I'm not quite sure what happened with her gastric emptying. So it is abnormal, 45% emptied at 4 hours?
That's correct.
And how much of the meal was she able to eat, the whole meal? Or
She said just a couple of bites.
couple of bites. So difficult to interpret that, isn't it? I guess she's losing weight. It's really a little bit worrisome. Gastroduodenal manometry is not easily available at most centers, so that wouldn't be necessarily what one would do. I hope you didn't do a wireless motility capsule because that would have given you a false positive.
I don't have that yet.
It's difficult to know. I mean, I would have tried to convince the patient how important it is to do that gastric emptying study and tried to convince her to do it again and do a 4-hour gastric emptying. That's what I would have tried.
Okay.
So there's no alternative to the standard gastric emptying study,
The-
other than gastroduodenal motility, which is
There
has
is.
limited availability.
Correct. Thank you, Rob. There is a spirulina-based stabilized stool breath test, but it's a 350 kilocalorie egg muffin kind of thing. And so if the patient can't eat, 2 bites of a scrambled egg, I'm not sure that I would have been able to convince the patient to eat a similarly large-sized meal.
Right.
So.
Okay.
So just a couple comments. I always worry when I see these type of patients that I'm missing an eating disorder. So I would really go through it, make sure that you've queried that and put that to rest. That would be obviously the behavioral change that would be totally different step. Second is that it sounds like she's got something post-viral and a gastroparetic post-viral, maybe even COVID-related, as I talked about the long haul, which is something that we're seeing is durable. We're seeing actually neurologic changes in some of these patients that don't necessarily on a CNS level may be permanent. We're not sure that they're coming back. So I'm not sure if she's in for the long haul or not, but I always find that and I think you said thyroid and everything else is normal, but I would make sure you're not going down the eating disorder just in a young woman that starts to have symptoms. But I'd bet on post-viral related.
And that's what we were thinking also. Because of the fact that she couldn't undergo a gastric emptying study, she couldn't complete it, her quality of life was significantly diminished. She was losing weight. We did try pro-motility agents with discussion about risks and benefits, and because of her continued decline, she tried a Reglan, and unfortunately that did work, but she had excessive drowsiness, so it had to be discontinued. And that gave us a clue also that we probably were dealing with a post-viral gastroparesis. We did try erythromycin. She had minimal improvement, but she had to discontinue that also because of loose stools and diarrhea. And we gave her a trial of prucalopride with no improvement at all. The last line there, our whole plan at the end was to try to repeat the gastric emptying study, especially given the Reglan that she had responded to, with the hope of, if she did, because she continued to lose weight, was to refer for G-POEM because of her inability to maintain her weight as well as her nutrition.
Okay, make one other comment. This patient, and it speaks to
Yeah.
Mike's about some of the IBS stuff as well. I always take a sleep history on these people, in particular because regardless if they're nauseated or they have irritable bowel or they've got abdominal pain, sensory thresholds get changed. When you have a poor night's sleep, and it takes about a week to renormalize that. And as you take any symptom, be it nausea here in particular, if you think about sleep fragmentation for anybody that's flown more than 2 or 3 hours in a time zone change, nausea is a very common symptom. So aggravation of nausea, independent of all the other stuff she's got, and her sensory thresholds going down, I think you can also start to make a patient feel better just by taking appropriate action on sleep. And it's terrible we never do this. The axiom I use is ask the patient how you feel when you get up in the morning. Do you feel refreshed and rested and ready to pop out of bed? The reason is that sleep is also amnestic, so you may have a cognitive awakening and not remember it. You can have a sensory arousal and not remember that, and you can have actually all these things where you may just the next day don't feel well. So it gets into a lot of functional, but aggravation of any symptom in this circumstance, I would take the history and then again try and normalize sleep as best we can. I use a lot of melatonin, by the way. No, in a very positive way. I use melatonin a lot.
That's good to know.
What's that?
So the question is, what about cyproheptadine or another medication like buspirone, 5-HT1A agonist for gastric accommodation? Cyproheptadine is used very much by pediatric gastroenterology. It improves appetite. It relieves a lot of these patients' symptoms. It would be a reasonable thing to try, I think. Another approach might be, before going to G-POEM, is to make sure the patient is blenderizing her diet and cooking it and taking a gastroparesis-type diet, and perhaps use anti-nausea medications on a routine basis, whether it's a 5-HT3 antagonist, which is much more likely to be available than an NK1 antagonist, so ondansetron and some.
The other thing, just Michael, you're the expert, but just from my practice, when I have a gastroparetic or somebody I think has gastroparetic, I'll tell them on a bad day I want you to go to liquids only, not just a low particle diet. Liquids always go through much more adroitly, I think, because if you have a vagatonic effect in the stomach, you lose capacitance, and so liquids are just kind of splashed through. and they can tolerate that. And if you put the patients on things like supplemental boost and Ensure and Clear Ensure and smoothies, and maybe those things are easier to keep them up. The other danger on these people when they start having vomiting is they then become dehydrated, and ketosis will perpetuate nausea. So you really have to stay ahead and ask them about urination frequency and thirst and those type of things. So again, a little bit more composite just on the focus of gastroparesis.
Okay, question?
Would you try Botox? Try that out, see if it would work?
So the question is, would you try Botox? Open label studies, 9 of them, all showed Botox works. 2 randomized controlled trials showed it didn't. So, but some people have actually advocated for trying Botox. If the patient responds to Botox, then they'd be a really good candidate potentially for GPOM, although that has not actually been shown in trials. But it's a reasonable thing to consider.
Can I ask a question? GPOM always it's made no sense to me if you get somebody late, because you've got this tonic, baggy stomach, and you've got to get stuff out. So how does GPOM work in patients that have maybe been held on too long, and you start to then say, how do you get things uphill rather than do an antrectomy and get the direction?
Great question. I don't think there are any data to tell us, whether the antecedent history, duration of the gastroparesis symptoms before GPOM influences the responsiveness to treatment. I don't know the answer.
One last question.
Comment on your use of domperidone. I've used it for 30 years in addition to small particle diet in anti-nausea, and it's been very effective.
Yeah, and domperidone is a dopamine D2 antagonist. It actually doesn't help the stomach emptying much. It's a great anti-nausea medication. It's not approved by the FDA. It requires special, application forms, et cetera. So if that's available to you, that's certainly something that could be considered.
A caveat on that, you can get it from Canada without any process, but what I tell my patients, and I use domperidone a fair amount, is you have to tell any new prescriber to do a search on this, because it's not going to show up on drug-drug interactions, and you really have to play this out. There are a number of adverse events and malpractice suits related to domperidone as it relates to drug-drug interactions. So be wary. We have the patients come in and do an EKG once a year. We have to see them every 6 months, and we reiterate any new medications has to be drug-drug checked, and I give them a handout on this, but they have to get their new prescribers to also do the same.
And in this day and age, you can also, do their pharmacogenetic CYP3A42D6 to be absolutely sure that your patient is safe. But again, domperidone was over the counter in Europe for many, many years, and then they started to get tachyarrhythmia deaths. And so it's no longer available over the counter, and it's very restricted in terms of how it can be prescribed in Europe. Something like 5 or 10 milligrams twice a day, I believe, is the maximum.
All right, so fantastic session. Thank you very much, and thanks for your attention.